Hello, my name is Christina Herrin and Director of Free to Choose Medicine at the Heartland Institute. Today we have an exclusive interview with Dr. Meryl Nass, physician practicing individualized medicine in Maine. Dr. Nass, thank you so much for being here with us today.
Thanks for inviting me.
I want to start off by asking you and wondering if you can explain what the role of government has been thus far in managing treatment in regard to COVID-19 and how decisions are impacting patients and doctors' abilities to make choices for themselves.
Okay. At the beginning of the pandemic, in the United States, we had very little idea whether there were any available effective treatments. And we looked to China, which shared a lot of information with the United States and with many other countries. They had over 200 clinical trials started in January. And in February, they published a paper that talked about all the aspects of how to deal with COVID medically. So from how to gown and glove and wear a mask to what sort of medications they were using in China for treatment. And this was, I thought, a very useful booklet that one of the top med schools in China put together. Then we also looked at what was going on in Italy and other places. And basically, in the beginning of this pandemic, there were no definite treatments that were established, but there were a number of treatments that were trialed in China, and basically the same ones were trialed in the United States and in other countries. And these included chloroquine, hydroxychloroquine, which are almost the same drug. One is a derivative of the other. Certain other antiviral drugs, interleukins, and a few other novel drugs that have worked for other viruses and might be useful. In addition, steroids were added for the late stage of COVID when people have an overwhelming autoimmune response, because the steroids will damp that down. So again, in the beginning, the basic treatment for COVID was nothing. It was supportive care. Supportive care means oxygen, IV fluids if necessary. You treat the symptoms, but you don't have something that you feel confident is actually going to stop the process that COVID has initiated, the COVID infection, which is a complicated process. In the beginning, you've got increasing viral loads in your body, and you need an antiviral. Then you start getting autoimmune features and blood clotting, and you need to treat those aspects of the disease separately. And then later on, you get scarring, you get other problems, and that again needs to be treated a little differently. But hydroxychloroquine and chloroquine seemed theoretically that they would be most effective early in the disease because they have antiviral effects. So when the number of viral particles in your body is increasing is when you really want to use them. They also have immune modulating properties and may have some benefit later on when a person gets into the second stage of disease, but it's not clear, and they weren't expected to have that much benefit in that stage. By the end, they probably have no benefit at all. Now, these drugs are both available in the United States and basically available in any other country. Hydroxychloroquine is considered slightly safer, although there's less safety information on it than there is on chloroquine. Chloroquine's been around for about 85 years as a licensed drug, and hydroxychloroquine has been licensed in the United States for 65 years. It's said that in 2017, there were 5 million US prescriptions for hydroxychloroquine. What that means is that doctors and patients have a great deal of experience with the drug. I've treated between 100 and 200 patients with hydroxychloroquine, and I myself have been treated with chloroquine, both for prevention and for treatment of malaria. So there was a lot of experience with the drugs. In many countries, in many third world countries, these drugs were over-the-counter drugs, just like Tylenol or aspirin. In France, chloroquine was an over-the-counter drug until right about the beginning of the pandemic, when it was made a prescription drug. In the United States and in most countries, you can prescribe a drug even if it has not been approved for the particular condition you're using it for, if it's approved for other purposes. And that is called off-label prescribing. So in other words, it costs a lot of money. It costs hundreds of millions of dollars or more to get a drug approved in the United States for a particular reason. And then it is often discovered somewhere during the process that it's good for other things. But the company making it doesn't want to spend another hundreds of millions of dollars to get it to go through clinical trials and get it approved for that other thing. So it's sort of, there's a tacit agreement amongst physicians and the FDA and the manufacturers that if it's already approved, it's considered safe enough and doctors can prescribe for these other reasons. And 20% of prescriptions in the United States are off-label prescriptions. Doctors are not writing a prescription for a drug for the reason it was officially approved. So doctors have always had the right to prescribe chloroquine and hydroxychloroquine if they wish, off-label for patients in the United States if the doctor and patient feel that there's an appropriate reason to do so. So the bottom line, and what's gotten confused, deliberately confused, is that efforts have been made to stop that process from happening. So efforts by the FDA, by the NIH, by CDC, by other international organizations, including the WHO, have tried in a large variety of ways to get doctors to stop prescribing a drug that they legally have every right to prescribe. And I'm happy to go into all those reasons if you want me to.
Sure. Well, just kind of digesting everything you said there, you made a lot of good points. And I just want to point back to the statistic that you mentioned, that 20% of drugs today are prescribed off-label, meaning that 20% of all prescriptions prescribed are prescribed for ailments that the label does not address or has not been approved by FDA. So that's super important, I think, for our viewers to recognize. I also want to dig deeper, just momentarily, into the clinical trial process of hydroxychloroquine for treating COVID-19. So as we know, and you mentioned, hydroxychloroquine has been approved for 65 years and is used today to treat arthritis and lupus, and has been used for malaria or other autoimmune diseases. So this off-patent drug is being used in clinical trials for patients, even though FDA has already approved its safety and efficacy to treat these other ailments. But in terms of COVID-19, they have yet to approve it for COVID-19 use. As you explained, it's very costly to go through the drug approval process. So are there any ethical concerns regarding the use of this drug in clinical trials for COVID-19 today, that patients must go through a clinical trial or be hospitalized to use hydroxychloroquine to treat their COVID-19 virus?
Okay. What a number of entities, several federal agencies, ministries of health, and the WHO have attempted to do is to stop, as I said, doctors from prescribing and patients receiving these two drugs for the prevention or treatment of COVID, particularly for treatment. And many mechanisms have been used because they can't stop, they have been unable to change the law on this. You would have to have, in the United States, Congress would have to pass a bill telling the FDA to stop all use of off-label drugs. And that would sort of throw the medical system into chaos, since 20% of prescriptions are off-label. So instead, there have been threats to doctors who have said that the drugs work for COVID. So those doctors have had their licenses threatened. They're being investigated by medical boards. In one case, Didier Raoult, a very famous infectious disease doctor in France, the New York Times said, "We want to do a big story on you," put his face on the front of the New York Times Magazine cover, wrote a big story, and made him out to look like he was a a maniac, and implied that he was conducting clinical trials in an unsavory fashion. And so now nobody, I've talked to reporters and they say, oh, we can't cover him. I mean, he's just off the wall. When this guy is considered one of the top doctors in France until he decided that hydroxychloroquine worked for COVID and started treating thousands of patients, and has said he has achieved less than 1% mortality. There are other countries that use this drug as well. There are about 10 other countries that are routinely using it. And they also say that when things are done right, they can achieve about 1% mortality, as opposed to the US, where initially we had 20 to 30% hospitalized patient mortality with COVID. Now we are getting down to the 10 to 20% range for patients who are sick enough to be hospitalized for COVID. We're losing at least 10% of them. Whereas in other countries where this drug is being used early, they're losing less than 1%. So if the drug is as good as many people say, but not everybody, certainly, it's very good and it's very important, and it could save tens of thousands or more lives. What the WHO did, they are conducting the biggest clinical trial on treatments for COVID in the world, and they have involved dozens of countries, hundreds of hospitals, and over 5,000 patients in their clinical trials. And they're trialing about 5 different drugs. Hydroxychloroquine was one of them. At first, they were not going to add the chloroquines. Later, there was a push by several countries to add them, so they did. But they did something very odd. The WHO created a very high dose for hydroxychloroquine that's approximately 3 to 4 times greater than what is being used in most places in the United States and the rest of the world to treat COVID. So most people who are treating COVID with this drug are using the same dose or very similar, that's used for lupus, for rheumatoid arthritis, psoriatic arthritis, malaria, and Lyme disease. But in the UK, and in a bunch of clinical trials in the UK called the recovery trials, and in a large number of trials that the WHO was managing called the solidarity trials, the dose chosen was 3 to 4 times greater. And in those trials, in the recovery trials, in the arm that used hydroxychloroquine, they had over 25% mortality in COVID patients who were hospitalized. This perhaps made it appear that the drug is ineffective. It just doesn't work. Or perhaps the drug, which is known to have what's called a narrow therapeutic window. In other words, it's a good drug if given in the right dose, but if you increase it, you don't have to increase it that much, and you run into severe toxicities, including cardiac arrhythmias, hypoglycemia, psychiatric effects, etc. And these can lead to death. So in Brazil, there was a clinical trial using chloroquine, and they used these similar very large doses, about 4 times normal. And after treating 41 patients, they had 16 deaths. And they said, whoa, we're stopping this arm. And then they continued testing low dose or normal dose hydroxychloroquine and chloroquine in Brazil, but they stopped the high dose, noticing that it caused arrhythmias and deaths. In the UK, using a similar dose of hydroxychloroquine, they have denied that it caused arrhythmias and deaths, which is very interesting, because if the UK was using 3 to 4 times the normal dose, and that didn't cause deaths and toxicity, then what the FDA, what the WHO, what everybody else is saying about the drug, which is that it's so dangerous, even at normal doses, can't be true. I mean, either high doses are safe, or high doses or normal doses are killing people. The claim that normal doses are killing people is what has been used to justify placing restrictions on the ability to prescribe the drug. So let me go back. Because doctors have the right to prescribe these drugs, efforts have been made going through everybody else, but not doctors and not the doctor associations to limit prescriptions. So some pharmacy chains, like CVS, will not allow, they will not dispense hydroxychloroquine for a COVID patient. They want you to write on the prescription what the drug is to be used for, and if it says COVID, they won't dispense it. Some pharmacy boards in certain states have said, we will not allow the drug to be dispensed for COVID. Some governors have issued rulings. In New York, Governor Cuomo said this drug can only be used for hospitalized patients, not outpatients, when we think it'll be the most effective. In New Jersey, the Bureau of Consumer Affairs issued a regulation that said the drug couldn't be used. I can't remember, in certain ways. I don't remember the details. Similarly, countries in Europe have issued these regulations. These are emergency. So under emergency authorities, governors and leaders of health departments gain powers that they don't normally have the rest of the time, and can quarantine, can demand patients be evaluated by doctors. They can demand an examination, quarantine you, quarantine areas, and potentially demand that you take drugs or vaccines. And apparently in this case, they demanded that certain drugs could not be used that were normally available.
Right. Well, thank you so much for breaking that down for us. And what other aspects should people be aware of in terms of using this drug for treating COVID-19? And what would be a better practice in the future in terms of creating pathways to, I don't want to say experimental drugs because this drug is approved, but drugs, I guess, for off-label use or unapproved therapies that could potentially treat COVID-19? What are better practices in the future to get government to step aside and let doctors and patients do what they do best, make decisions for themselves, and y'all do what you do best, prescribing safe, effective medicine?
Well, the government doesn't like to step back if they have an opportunity to, issue an edict or a regulation. You don't actually need new regulations in order to use experimental drugs in emergencies. There are bills that have already been passed after 9/11, allowing, again, governors or the heads of certain departments in the United States, so certain secretaries can issue rulings that a drug or a vaccine, even though it isn't licensed, maybe it's never been tested in humans, maybe it's never even been tested in animals, but they have the ability to issue a ruling that it can be used in humans. They don't have the right to force you to take an unlicensed drug that has not been approved by FDA, but they can make it available to you. And when that happens, it is under the condition that there will be no liability on the part of the manufacturer. So if you get sick from an unlicensed drug or vaccine that was approved under emergency regulations, you can't sue unless the manufacturer knew that it was providing a substandard product and was knowledgeable about that ahead of time. You have no right to sue. Best you can do is go to the Department of HHS and attempt to get a small stipend up to $250,000 maximally, if Congress has appropriated money for that, and if the DHHS approves it. If the drug is licensed and an emergency use authorization is issued for it, that also gives the manufacturer, even for a licensed drug, the ability to provide it without being subject to liability. That's a problem because what happened is that Peter Navarro was able to obtain from about half a dozen different drug manufacturers supplies of chloroquine and hydroxychloroquine that were donated to the National Strategic Stockpile in the United States for possible use for COVID. And this was done under the emergency use authorization, one of these regulations that was passed after 9/11. But what actually took place was that some of this product, the chloroquine that was apparently made in Pakistan, was substandard, was adulterated, and it was said it would never have been able to pass FDA requirements. It would never have been approved by FDA. But it is in the national stockpile now, and you and I, the citizens, we might want to use it, we might need it, but we don't know what its qualities are, why it wouldn't pass FDA inspection, and whether it's something we actually want to swallow or not. There are other issues with some of the hydroxychloroquine in the national stockpile now, that it was expired and was then put into the stockpile for use under the EUA. Whether you want to use an expired drug again, I'd like to know how, if it was just expired for a few months, sure, I'll take it. But if it's 10 years expired, I don't think I want it anymore. So we don't know at this point which of those pills have these problems. And although it would be wonderful to have access to the 60 million or more tablets in the strategic stockpile of chloroquine and hydroxychloroquine, we don't want them provided to the population willy-nilly. We want them separated on the basis of what was approvable by FDA and what wasn't, what the problems were, and let the patients decide, not just give it out to hospitals or to other entities and not explain why this is not a licensed drug. If you go to a drugstore, if your doctor gives you a prescription, and if you live in a state or a country where you're allowed to actually have this drug dispensed to you for COVID, you will not be getting drug from the strategic stockpile. You will be getting a drug that FDA has put its stamp of approval on. So that is clearly what we want to use first.
Well, thank you for that information. And do you have any final thoughts for our viewers on the subject?
Hydroxychloroquine probably works quite well in most patients with COVID. It is not a total magic bullet. There are still going to be some people who get very sick or who die. And there are other people who, for various reasons, can't take it. If they have a genetic issue or if they're on other medications that don't work with it. But it appears to be, and there are many studies, but most of them have not been peer reviewed, but there's 50 studies out there that say it is useful to some degree in COVID. The fact that this drug has been withheld from us is in very unsavory ways by pulling on the levers of government to sort of threaten doctors that it's not the standard of care. They might be subject to malpractice if they give it, by designing clinical trials in such a way that they fail to show benefit when there probably is, because you're giving the wrong dose, by publishing a paper in the world's most popular medical journal claiming that chloroquine and hydroxychloroquine kill patients at a rate 35% more than patients who didn't receive these drugs. This paper was published on May 22nd. It was supposed to be the largest study of its kind, 96,000 hospitalized COVID patients, of whom 15,000 had received a chloroquine drug. And it turned out that the entire paper was came out of thin air. The database did not exist. The hospitals didn't have that number of patients. The young doctor who claimed to own the database could show no evidence that any of the hospitals he said were part of the database actually had anything to do with him or his company. So it was a huge scandal. But what happened was the scandal part never got covered in the media. So most people heard, it was blared on the televisions, that hydroxychloroquine kills. This was on May 22nd. Everybody heard it. Then over the next couple of weeks, it turned out that the paper was a complete fabrication. Very few people have heard that the paper was a fabrication, and this 30% higher death rate has not been shown in any other study. So it was a falsification. The fact that these things have happened, the fact that the NIH issued guidelines for the use of hydroxychloroquine and other drugs and said absolutely shouldn't use it, and it turned out that 16 of the guideline authors that NIH had chosen actually had a financial conflict of interest with Gilead, the maker of remdesivir, and remdesivir is the main competitor for hydroxychloroquine in terms of what treatment to use. So, as I said, there have been many unsavory actions that have taken place. This is still to be unraveled and explained. We don't understand how such things happened, who pulled the strings, but right now, people are being harmed, and the pandemic may be lasting longer and may be more severe because patients in the United States and many other countries are having this drug withheld from them. So it's something everybody should be concerned about.
Well, thank you so much for taking time to talk with me today, and I greatly appreciate your insight on this.
Thank you, Christina. Take care.